this invitation, and thank you, Chairperson, for kind words of introduction. What I am going to talk in next 20 minutes using continuous glucose monitoring in type 2 diabetes. So first let me ask, how many of you are using continuous glucose monitoring in your clinical practice? And how many of you are convinced that for type 2 diabetes, CGM, I will not say must, but is an appropriate monitoring device for people with type 2 diabetes? So I tell you, before 30 years, when we were medical resident, I was in medical MD medicine, second year, we used to run a diabetes clinic. And probably in that city, Ahmedabad, to get HbA1c for everyone will not afford it. And there was always a debate whether we should get A1c or not. I'm sure all senior professors and doctors will be knowing about it. And we were having in our medical school also a WHO-sponsored, supported HbA1c lab also. But still, to get HbA1c, you had to get HOD medicine, he has to sign. Okay, get HbA1c for this because it was free, public hospital. And the treatment was decided only on the basis of a person who will come with a fasting and a post-meal glucose level with a one report. This was a situation in India in 1995-96. This is what I know. And across country, because later on after that I came to here, before I went my Denmark for fellowship, I was here to understand how Dr. Mohan Center and Dr. Ramchandran, they are doing in DRC. People used to come early in the morning, getting their fasting, then they used to take breakfast there only, and then again to get the post-meal sugar. And on that basis, the doctor will decide. That was actually a sugar of that particular day. You don't know whether a previous day patient has taken medicine or not, and you are going to increase or decrease the dose of medicine. Even I was here in the government medical college to see also how Stanley works. So the same situation before 25-30 years, now I think situation is same, whether to consider HbA1c versus continuous glucose monitoring. Now, confusion is whether CGM, whether self-monitoring of blood glucose, or whether A1c, what we should follow, and that I will talk in this particular talk. We know that dysglycemia is a major challenge. We are also worried of chronic hyperglycemia. We are worried of hypoglycemia because you don't want your patient to go in hypoglycemia. So that was again a challenge before 30 years. If suppose on that particular day patient sugar is high and you want to increase sulfonylurea, but in between patient will say that, I had 2 episodes of hypoglycemia in last 2 months. That was a leading question you asked to ask. And then rather increasing the dose, we used to decrease sometimes the dose also. That was the situation in those days. And the glycemic variability is also very, very important, challenging, which we understood from DCCT, because there is 2 different varieties of patients who are achieving tight glycemic control. Still, one of them were getting more complications. So the reason was a glycemic variability could be a reason for them, and that was an explanation for that. So there are unmet need in glucose monitoring. So the second question comes then, why can't we do self-monitoring of blood glucose? Instead, that has become very popular instead of doing a continuous glucose monitoring. So self-monitoring of blood glucose means randomly checking the sugar. Like suppose this meeting have 1,000 doctors who were registered, but here in front of me, hardly 100 doctors are there. So randomly, if you say someone 1,000 doctors have attended the meeting, but actually if you do continuously monitoring, then you will see, no, this is what the exact situation is. 100 doctors are there in this particular talk, and then how many of are listening, how many were going out, how many of them coming in. That is what a continuous video recording. So instead of getting a random photograph, if you are doing a continuous video monitoring, I'm sure CCTV will give you much more information than just getting a one report of random photograph of that. This data which we have published, this is what people who are actually state of glycemic control, even those who are achieving uncontrolled diabetes, one of the important reason for our country is because we are not monitoring. And this data which we have published, the 2/3 of our diabetic patients are actually not monitoring, and that's the reason they have uncontrolled diabetes. We have multiple issues for type 2 diabetes management. Definitely complication prevention is a major challenge, but these 2 are very, very important. One of them is having a hyperglycemia, particularly post-meal, glycemic variability, and very important reason for us to monitor our patient continuously is not to have them hypoglycemic. So that's what the hypoglycemia. There is a limitation of A1C. A1C gives you information of last 3 months. It just gives you the information retrospective, what happened to you in last 3 months, what was your average sugar. It does not give you any information what you can do prospectively, how you are going to change the therapy and give you the better control, unless you are going to do a continuous monitoring for these patients. So retrospectively, you may have A1C of patient and two different varieties of patient you may have with the same A1C also. Someone who is multiple hyper is still A1C may be good, but someone have lesser hyperglycemic variability is still A1C of same. So you may have two different type of patient with the same A1C, but still both the patients completely have different behavior. So A1C does not give you truly about continuous, glucose condition, and does not give you any information about the hypoglycemia or any glycemic variability. What is continuous glucose monitoring? Since last almost 8-10 years, now we have CGM uses, but actually CGM had come to our country before 20 years. It was Medtronic continuous glucose monitoring independently also we used to use. It was only for 3 days. A graph was also very difficult to interpret and it never became popular. We used to use only CGM whenever we used to put the patient on insulin pump therapy. But then later on, the 2015 onward, when Abbott had introduced, originally it was Libre Pro, but then it had come with a Libre, now Libre 2 Plus also, and this gives you interstitial fluid glucose monitoring. So something which is a sensor, and then there is a transmitter which is actually above in it, and from transmitter the information goes directly in your mobile or in your system. Now there are glucose meter reader also, because some of the patients who are not using smartphone, even they can use the readers too. But actually it had become more popular after we started using this software. Software we call this ambulatory glucose profile. This ambulatory glucose profile, actually this software gives you such a beautiful image that you can interpret it so easily. And that's the reason it had become very popular. Rather, it is a report of 14 days. Previously, we used to do with the Medtronic with 3 days report, but still it was more confusing because of multiple. But this is a graphical presentation. Absolutely, you can educate the patient. You can educate the patient that this is the time when actually your sugar is more. This is the time when your sugar is low. This is the time when you are outliers, like some 10% of the time your sugar fluctuate like this way. So you can explain multiple things on a graph, because that ambulatory glucose profile graph, which is a software generated, had really made it very, very popular. It gives you the information about your time in range. It gives you information about time above range. It gives you information about time below range. So all information you can achieve from this also. So these are some of the key benefits. One of the biggest benefit, which I believe from ambulatory glucose profile graph as well as with continuous glucose monitoring for healthcare professional, this can be on your desktop. So even you can distantly monitor the patient. You can do the e-consultation, and patient is using continuous glucose monitoring. Patient may be in US, maybe in Australia, maybe in any part of the country or any part of the world. Still you are getting the information directly on your desktop, and you can distantly talk to patient. E-consultation had become very, very easy. What's the customized time in range and what we should do for Indian patient? I was the one who was the part of this international consensus guideline. The first time in 2017, along with ETTD in Paris, more than 50 experts from all over the world sit together. I was lucky to be the part of this particular group of experts, and we had come out with a clinical targets of continuous glucose monitoring. So continuous glucose monitoring, those who are using, then what should be the targets for them? And the targets came as a time in range. So as a part of this consensus guideline, this we have published in 2019, the consensus for CGM data interpretation. Any type 1 or type 2 diabetic patient who is coming to your clinic, any garden variety of type 1 and type 2, on continuous glucose monitoring, more than 70% of the time, their sugar should be between 70 to 180. And that's what we call it time in range, TIR. Now, time below range means below 70. It is not acceptable to go more than 5% of the time. Same way, when the sugar goes more than 180 to 250, we call it grade 1 hyperglycemia. When it goes more than 250, the grade is known as grade 2 hyperglycemia. It is not acceptable for someone to go for grade 2 hyperglycemia more than 5% again. So I mean, if you have a patient either going more in hypoglycemia or more in hyperglycemia, you have to change the therapy and try to achieve time in range in this. But suppose someone is elderly, high risk, frail, risk of hypoglycemia is more. You may not be very tightly controlling these patients, but still it should be more than 50% of the time their sugar should be in the range. It should not be like that they are completely out of the control. And it is not acceptable for an elderly patient, for a frail patient, for a long duration of diabetic patient to get their hypoglycemia even more than 1% of the time. So in 24 hours, even if they get one episode of hypoglycemia, it is not acceptable. We have to change the therapy. By any means, hypoglycemia is not acceptable. Now what about pregnancy? Someone who is first time detected diabetes during pregnancy like 2-GDM or hyperglycemia in pregnancy, 95% of the time their sugar should be in control. 63 to 140, not 70 to 180. We are getting them or more tighter control, and this is in pregnancy and type 1 diabetes, where a type 1 diabetes more than 70% of the time they should be in the range of again 63 to 180 milligram. What is the recommendation? Recommendation, you try to achieve these patients with the more and more tighter control by different therapies which are available. For an Indian type 1, Indian time in range consensus, we had come out with Dr. Mohan and many more experts from all across the country, an expert consensus recommendation on time in range for type 1 and type 2 diabetic patients in India who are using continuous glucose monitoring. These are some of the patients to whom we had used in our clinic, and we can explain the patient easily that this is your mean, this is your time below range, this is your in range time, and this is, these are the times when your sugar is high. And you can easily understand these are the post-meal hyperglycemic peak, which either you can control with the molecules which are primarily controlling the prandial glucose, or you are going to use the molecules like GLP-1 or SGLT2, which also helps these patients. So need for Indian diabetic patient is one of the reason is we are eating lot of carbohydrate. So many of the times you may find is somebody is uncontrolled diabetes, as per international recommendation, uncontrolled type 2 diabetes, who are on 3 or 4 drugs of oral anti-diabetic agents. I am sure all of you will agree that patient should be started on insulin therapy. Now again, which insulin therapy? It is a glargine which is recommended, or it is a longer acting insulin which is recommended. Now a patient of 8 HbA1c in India will primarily have a post-meal hyperglycemia. None of the patient is going to have their fasting is more than 100 or 110. If you put that patient on an uncontrolled diabetes, considering putting them on a insulin or any variety of premix insulin also, going to lead a lot of hypoglycemia in midnight. So that's the reason if you convince the patient by putting them on continuous glucose monitoring, you will also able to convince the patient for a nutrition counseling. Otherwise, they will feel, no, I am not taking that much amount of food. My sugar is uncontrolled. I don't know. So these patients who are actually on 7.5, 8 or 8.5, many of the time, just by putting them on continuous glucose monitoring, nutritional counseling can be done so much so that their sugar gets controlled even without much intervention and not by adding any other therapy. We have data to support that a patient who are achieving a tighter glycemic control in compared to person who is not getting this time in range will have more complication. Even the cost reduction also. Sometimes somebody may say that CGM using is really very costly, but there are data to support that a person who is not achieving a time in range or not controlling glycemic variability develop more complication. And in diabetic patient, it is always treating diabetes is cheaper than getting a complication, because treatment of complication is much more higher in compared to treating diabetic patient. There is a cost reduction definitely by improving patient time in range, particularly in type 1 and type 2 diabetic patients. There are benefits in a special population, particularly in pediatric, in pregnancy, as well as in geriatric population. So these are the population, special population. They will get more benefit by using continuous glucose monitoring, and the people who are taking a lot of carbs in their diet will also get a lot of benefits. The recommendation is very, very clear. All those who are can go in risk of hypoglycemia or achieving HbA1c of around this much below 8, and still we are not able to achieve less than 7. They should be on continuous glucose monitoring. It definitely decreases the other complications like micro and macrovascular complication too. Now, where we should use in our routine clinical practice, in RSSD in 2022 guidelines, as well as in American Association of Clinical Endocrinology guideline in 2020 onwards, the CGM is been recommended even for managing type 2. For type 1 all over the world, from 2019 onwards, they all accepted that all type 1 diabetes should be on continuous glucose monitoring where it is possible or wherever it is feasible. But what about type 2 diabetes? Definitely those who can afford, they should be on this. This is what one more paper which we have written from South Asia as a Southeast Asia chairman. This is one paper with Dr. Anup Mishra. Those who can't afford regularly, at least intermittent uses of this can be used. And it's a time in range. It also should be considered as a very target for a type 2 diabetes. That's an urgent need. These are some of the consensus which we have written. There are evidence to show that not only decreases A1C but also decreases the complication. This is one replace trial which is replacing the patient from SMBG to CGM. This is one CGM used in type 2 diabetic patients. These are some of the paper. As I told you in ACE 2020 guidelines, they had put very clearly in type 2 diabetes management, try to use in CGM. Even the ADA also had put, this is the ACE. And this one last slide, I will take 1 minute more just to explain you that this is one patient who had come with a very uncontrolled diabetes with 9 HbA1c. This patient was already on all different oral anti-diabetic agents. So patient was on vildagliptin twice daily, metformin, patient was on sulfonylurea. So 3 oral anti-diabetic agents with the highest dose of 6 milligram of glimepiride with everything was given. This is the sugar. I am sure patient had gone 4-5 places and everybody will agree that 9.5 patient should be on insulin. There is no doubt about it. This is what the guideline is recommending. Patient had come to me. I told them, yes, you should be on this. Let us put you on continuous glucose monitoring. We call back patient after 5 or 6 days. And we had shown that, see, your all sugar are very high and you should be on insulin. There is no doubt about it because all sugar are high. So on first day, when we were saying that we put him on GLP-1, that time on a daily Victoza was available, we had put on that patient and see that after 3-4 days what will happen. After 5th day when patient again came, the sugar was high, we had put on SGLT2, but on 6th day onward the sugar started getting down. And this is the 6th day report. Patient was not on insulin, we removed the metformin, vildagliptin, metformin, SGLT2 and liraglutide. We continue him on the liraglutide. We increase the dose to 1.2 only after 6 days. And this is the report after 4 days. And sulfonylurea actually from 6 milligram, here I decrease it to 2 milligram. On 7th day, 8th day, 10th day when patient came, we stopped glimepiride. And the patient remained only on GLP-1, metformin and SGLT2. And here you can see all 4 reports, sugar absolutely well controlled. So this is what the guideline is recommending. This patient should be on insulin therapy with a 9 HbA1c, and the patient who has put on a therapy which is actually, they are saying not insulin, this we had put on GLP-1 and SGLT2, and you can see absolutely well controlled. So a simple CGM can change the way how you are treating diabetic patients. Era is now there, that now we are in this era. Probably in the future, each and every patient of us will be on continuous glucose monitoring. But at this point of time, I will recommend that all of us need for our patient is A1C definitely, finger stick also, and as and when required, continuous glucose monitoring. Actually, at this point of time, they are complementing each other. We can't say that only CGM because all patients cannot afford for it. To summarize my talk, CGM can provide insight which becomes more personalized diabetes management plan. You can decide that this will be right treatment for you, very personalized, very precise treatment for that particular patient, not like guideline based. AGP graph is a very valuable, and we know that there is no one size which fit for all. You can't say that 2 different patients will have 2 different varieties of therapy can be given to them, and recent recommendation consensus paper provide insight into incorporating CGM even in Indian context also. With this, I thank you everyone, and once again thank you organizing committee for giving me an opportunity. I welcome all of you as a National Secretary for Diabetes India for World Congress of Diabetes India. This year we are going to have at Chennai from 13th to 15th of Feb 2027. Visit us for more information on our website. Thank you, sir. Thank you.